Welcome to my video. Just to let you know, I have no financial interest. To get new educational videos and updates, please subscribe to my channel. I'd be very grateful if you could please like and share this video, which I hope will give you a beneficial knowledge.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد أشرف المرسلين. السلام عليكم ورحمة الله وبركاته. In this video we are going to discuss the secrets or how to interpret the retinal spectral domain OCT scan. So first, what is the meaning of optical coherence tomography or OCT? It is high resolution cross-sectional imaging of the retina that is done by using optical light, which is laser lights, and it is coherent, and then with the reflectivity of this light we can determine the distance and the structures in the eye. The spectral domain OCT now becomes a very essential part in ophthalmology practice and especially retinal practice, and sometimes in our clinic, before we see the history of the patient, we see the OCT scan image. I know this is not typical, but this is what happened in our daily life, and there is no retinal clinic without OCT. In the exams, it is very essential part of the exams. All the postgraduate exams, you're going to be asked about OCT, especially FRCOphth exam. And in the COVID-19 pandemic era now, we are changing into virtual clinics and tele-ophthalmology and screening and artificial intelligence. All of this needs imaging, and the most important imaging in the retina is the OCT scan. So first, this light that goes inside the eye, we can analyze the reflectivity of it, and then we can determine the distances, and then we can have more than one A scan to get the transverse scan, and then the B scan and the different reflectivity. So after you do thousands of A scan, the computer can generate an image which gives us the reflectivity of the retinal layers, which we call the B scan, and this can diagnose a lot of diseases. You can obtain a three-dimensional image as well, and this can help in diagnosis of different diseases. Now we have the wide OCT scan, which is 16.5 millimeters and gives about 55 degrees of the retina. So this helps especially in cases of diabetic retinopathy. We have now the swept source OCT, but we're not discussing it in this video. And we have the ultra wide, which is the 23 millimeters OCT scan now. And the other image that gives us a coronal section on the surface of the retina, and we can see the blood vessels as well and the different layers, which we call en-face OCT or the C scan. And now we have the wide en-face mosaic OCT. So let us know now how to read the OCT scan if you have a machine in your clinic or if you have it in your exam. So we have to start with the image quality, and the image quality you have to exclude any artifacts. So you have to check where is this scan taken from the near infrared reflectance image in some machines to determine what is the location of this scan. And you see here the papillomacular bundle. So the nerve fiber layer nasally near the optic disc is thick, which is a normal finding. The shadogram as well in other machines is very important to have a look on it first to make sure that there is no optical abnormalities during taking the scan. And if it is clear like this case, so you can analyze the scan without artifacts. So the common artifacts that you can see first is the motion artifact, the off-center artifact, and the blinking artifact here, and then sometimes the software is not working properly, which we call it software breakdown. And the first step, you have to tell us in the exams or in the reports which eye. You have to know which eye first, and all the ophthalmic investigations, if you see the disc or the blind spot on the right side, so it goes with your right hand, so this is the right eye, except the MRI and the CT scan and the electron scintillography. So if you find the nerve fiber layer, which is this layer here on the right side, so this is a right eye, and if you find the nerve fiber layer, which is here, this hyperreflective white band on the left side, so this is the left eye. So usually the retinal nerve fiber layer is thick nasally, so this identifies the eye. So if you know that, can you tell me which eye is this? So now you find that the two bands are equal. So if you see here the near infrared reflectance image, and you see the orientation of the scan here is vertical, so in this case, if I give you this OCT only, you cannot say which eye is this. So that's the importance, that you have to be oriented about the location of the scan. Can you tell me which eye is this as well? So now here you cannot identify the thickness of the retinal nerve fiber layer, and this is you can find it in pathology of the optic nerve, like advanced glaucoma and optic neuropathy, due to various reasons, either nutritional or other causes. This makes the retinal nerve fiber thinner, and you cannot identify which eye if I give you this scan alone. So the second step is you have to be oriented with the retinal layers, the 10 layers that we know from the anatomy, but you have to be oriented with the foveal layers as well. So this is the most important slide in our video today. You'll find the retinal OCT layers are 12 layers, not only 10 like the histology and the anatomy. So we will go layer by layer now. So from outside in, you'll have the RPE layer, which is the first white line from outside, and this is the RPE, which is the retinal pigment epithelium with the Brooks membrane complex as well, and the outer segments of the photoreceptors and the inner segments, and then the external limiting membrane and the nuclei of the rods and cones, then the Henle fiber layer, which is the axons of the rods and cones cells, and then the dendrites, which is the outer plexiform layer. Then we will have the bipolar cell and the horizontal and amacrine cell forming the inner nuclear layer. Then the dendrites is doing synapses with the ganglion cell layer here. So this is the inner plexiform layer, which is formed of three hyperreflective bands. Then the ganglion cell layer, which is the hyperreflective band, the inner one, and then the nerve fiber layer, which is hyperreflective, and then the internal limiting membrane. So the molar cells, which is one of the most important cells in our retina, is having the outer foot plate, which forms the external limiting membrane, and then the nucleus is inside the inner nuclear layer. Then the inner foot plate, which forms the internal limiting membrane. So to go again layer by layer, you will find here, this is the hyperreflective layer, which is the RPE with Brooks membrane. Then the ellipsoid zone, which is one of the most important hyperreflective lines that you have to identify in the normal OCT scan, which is hyperreflective but less than the RPE. And then the external limiting membrane, which is faint white line, which represent the foot plates of the molar cells. Then the hyporeflective, which is the gray area here, is called the myoid zone of the inner segment of the photoreceptor. Then this hyporeflective area is the outer segment, with the hyporeflective zone that has some debates around the origin of this zone. We will discuss it in the next slides, but in most of the evidence till now, it is the interdigitation zone, which is part of the outer segment of the photoreceptors. So the outer nuclear layer, which is the nuclei of the photoreceptors, is this area here, but there is another area which is the axonal part of the photoreceptors, which is the Henle fiber layer, and then the dendritic part, which is the outer plexiform layer. So these two layers in the histology is one layer, and these two layers here in the histology is one layer, so that's why we have the 12 layers. Then we'll go with the layers after that: the inner nuclear layer, the inner plexiform layer, and then the ganglion cell layer, the nerve fiber layer, and the internal limiting membrane. So in this average scan, you can find the layers are more clear here. So we have this outer layer, which is the RPE Brooks membrane complex, and then this is the interdigitation zone, then the outer segments of the cones, and then the ellipsoid zone, then the myoid zone, and then the external limiting membrane. And if you see here, you can find the difference between the gray area here. This is a deep gray area, and this is less gray area. This is the outer nuclear layer, and this is the Henle fiber layer, which is displaced to the sides. And then the outer plexiform layer, then the inner nuclear layer, inner plexiform with its three bands, and the ganglion cell layer, the nerve fiber layer, and the internal limiting membrane. And you can see that the reflectivity of the RPE is the most hyper-reflective line in the OCT scan, because it is very packed cells and it is perpendicular to the light of the OCT machine. Then the ellipsoid zone, which is the tightly oriented photoreceptors as well with the mitochondria, it's more reflective than the other layers. Then the external limiting membrane here, and then the internal limiting membrane is hyperreflective near the ellipsoid zone reflectivity. So you will find here that the plexiform layers are slightly hyper reflective because of this orientation of the synapses between the cells, but the nuclear layers are gray because they don't have any hyper reflectivity, because there is no axons that are hyper reflective in the path of the laser light of the OCT machine. So you have to be oriented with the thickness of every layer and the reflectivity of every layer in relation to the other layers. And the RPE and the ellipsoid zone is the most important two lines that you are searching for. If you find it very clear and pristine as this scan, so this is an indication that the vision of the patient is expected to be good, except if is having any amblyopia or any central cause. But in general, if you find the scan like that, you are expecting the vision to be good. And the foveola, which is the center of the fovea here, is very important to identify the structures. So you have the RPE and then the cones only, and this cones in this area is having special character that are longer than the cones on the sides, and the Henle fiber layer is displaced laterally in this area. And we have to identify as well the blood vessels in the nerve fiber layer that disappear in the area of the fovea, which is the foveal avascular zone here. So you have to be oriented with this anatomical normal structure. And there is central lengthening of the outer segments of the photoreceptors in this area here, in the area of the foveola. So some trainees are coming saying that they find an abnormal area here in the center of the retina, which is this hump here, and they are asking why this line is not straight as the RPE line. So this is actually very normal appearance of the ellipsoid zone line at the center of the fovea here, because of the lengthening of the outer segments of the cone photoreceptors in this area. The Henle fiber layer, which is the axonal part of the photoreceptors, is a separate layer in the OCT because the reflectivity is different than the outer nuclear layer and the outer plexiform layer. And if we take an en-face image, which is a coronal section, you can see here the nice Henle fiber layer striations, which you can see when you have any exudates or any pathology in this layer, like the neuroretinitis. You can see the exudates is accumulating in this layer in this radial appearance. So the Henle fiber layer, if you see here our OCT scan, there is this faint change between the outer nuclear layer and the outer plexiform layer, and the Henle fiber layer is this layer, which we put it as the yellow band here. So there is an article in Retina in 2015 that shows that when we project the light of the OCT scan in a different way, we can have different thickness of the Henle fiber layer. which means that the fibers are different than the outer plexiform layer. And when the scan is tilted as well, this is another article in 2011 as well. It's showing that the vertical scan is not changing the thickness of the Henle fiber layer, but the horizontal scans, if it is having different orientation of the lights, this can give different thickening. So this is normal. This is not something which is abnormal. This is just if you have a tilt of the scan, you can have this changes. So this is one of our cases that have tilted disc as well. And if you see here, you can identify that the Henle fiber layer is thicker on this side, but this is not a pathology. This is just orientation of the light during the acquisition of the image from the OCT scan. And if we take in the same patient, if you take a horizontal scan, you can find that the Henle fiber layer here is slightly hyper-reflective than the usual, but it is equal thickness on both sides. So you have to identify this, not to interpret it as a pathology. Then the outer 4 hyper-reflective bands, we have a recent article in 2018 in Ophthalmology that studied the cellular characteristics of the OCT and the outer retinal bands using specific immunohistochemistry markers. And they found that, so if we take the layers from outside in, the 4 hyperreflective bands here that we can see here on the OCT, the first line is the RPE, but it is the mitochondrial zone. Then there is a very faint hyporeflective line here. They call it the melanosome zone, and then there is a hyperreflective line. This is the second one here, or if we take it from inside out, it will be the third band here. They showed that, according to their study, that this represents the phagosome zone of the RPE. Then the hyporeflective line, which is here, this represents the outer segments, which is elongated in the center, and the interdigitation zone between the outer segment and the villi of the RPE. Then the hyperreflective zone, which is part of the inner segment, this is the ellipsoid zone, which have the mitochondria of the photoreceptors. Then the myoid zone, which having the other organelles, is not hyperreflective. Then the external limiting membrane, which is the outer plate of the molar cells, this is the fourth line. So this is the representation of the 4 hyperreflective bands. If you take it from in out, so the faint one is the external limiting membrane, then the ellipsoid zone, and then the phagosome zone, and then the RPE mitochondria zone. The debate is in this third line here. Is it the interdigitation zone or the phagosome zone? At least it is the junction between the photoreceptors and the RPE. So till now we are not sure 100%, but according to this study, this represents the part of the RPE that is the phagosomes of the outer segments of the photoreceptors. This is why it is hyper reflective. And in this article as well, you can see that they identified the Henle fiber layer as our interpretation before, and this is the phagosome zone that is nearly as the markers of the outer segment, so it is part of the RPE and part from the photoreceptors. And here is the phagosome zone, which is yellow color, and the RPE, which is the red color here, and then the outer segments here. So the phagosome of the area that is junction between the photoreceptors and the RPE. If we see the pathology as well, you will find that here the 3 layers, which is the part of the photoreceptors, are going up with the detachment of the retina. So we can see that these 3 hyperreflective layers go up. So this is an evidence that it is part of the photoreceptors, and I go more with that it is the part of the interdigitation zone, the junction between the RPE and the photoreceptors. And the other thing here, if we have a subretinal collection of material like cases of adult vitelliform macular dystrophy, you find that this third band goes up with the this collection of the material. So this is an evidence that this line is part from the photoreceptors and not from the RPE. But anyway, if you find that in this case here there is loss of the second and third band here, which is the ellipsoid zone and the interdigitation zone, this is a case that came complaining of conjunctivitis in the eye and redness, and she's about 60 years old female, and while doing the OCT, because she was diabetic as well and we want to check the back of the eye, we found this incidental finding, and her vision in this eye was 6/36. So if you compare here the OCT with the normal OCT, you can find that this ellipsoid zone and the interdigitation zone are lost here, and the thickness as well of the outer nuclear layer is lost here, so it is very thin, which means that the photoreceptors are lost. And during taking the history, everything was negative except when we asked her about looking in the sun or sun gazing. She was saying that she's looking in the sun for some time, and she was following the sun, and when we take a detailed history, we find that she is schizophrenic actually, and she had long history of looking in the sun. So just I want to emphasize the importance of the outer bands of the retina here, which is part of the photoreceptors. If you find it lost, so the vision is not going to be expected to be good. So this is the photic or the solar retinopathy, and the segmentation of the layers can be done now by softwares, and the artificial intelligence as well is using this segmentation, and some machines are doing this segmentation to identify the ganglion cell layer, for example. This is important in the glaucoma follow-up as well. So the third step in our interpretation is the reflectivity. So you have to identify the reflectivity of the layers. So the hyperreflectivity is the white structures, the hypo is the black, and the iso is the gray. And then there is shadowing. It is very evident here from the normal blood vessels. So you have, this is the normal blood vessels, and you can find that it makes this shadowing, because some trainees as well are finding this a little bit abnormal finding when they look to the OCT, but this is very normal that you have the shadowing from the blood vessels. The reflectivity, you have to identify where is the hyper or hyporeflective structure. So the location is important. Either it is pre-retinal here, or epiretinal, which is on the surface of the retina, or intraretinal, or subretinal, which is under the third band that we identify on the OCT, or sub-RPE, which is under the RPE. And this is a nice case that shows the difference between the subretinal and the sub-RPE. So this is a case of drusen and reticular pseudodrusen. So actually this is the line of the RPE here. Then you can find that the drusen is under the RPE and the pseudodrusen is above the RPE layer. The other color display, or the false color display, that some people like to use is the showing the reflectivity by color. So the hyperreflective is the red color and the hyperreflective is the blue color, but I don't like this display because it is a little bit distractive to me, so I prefer the gray scale. So the first thing you have to identify in the layers is the RPE ellipsoid zone, and then you go up to the inner layers, and then you go down to the outer layers, which is the poriocapillaris, the choroid, and the sclera. So this is a nice case that was referred from our strabismus colleagues, that they found an abnormal structure when they did an OCT for this patient. And they refer him to us. So what's your opinion? What is this abnormal structure? So actually this is the 4 layers that we identified before, the 4 outer retinal bands, and actually this is the normal area of the retina. And with the detailed examination and history, we find that this is a case of retinal dystrophy, retinitis pigmentosa, and all these outer layers are lost here. So this is the importance of identifying the normal structure. This is a case as well that had systemic lupus erythematosus, and she's using the hydroxychloroquine, and you can see this is advanced case of hydroxychloroquine toxicity. She was using that for about 20 years, and you find here loss of the outer retinal layers, especially the ellipsoid zone. So you're not expecting the vision or the visual field to be good in this area, so only she's seeing like a tunnel vision. This is another case of an autoimmune retinopathy. So you can find that the ellipsoid zone is slightly faint here, and it is lost in this area here. So and the hump as well, or the elongation of the photoreceptors is not present. So this is an indication that there is something wrong with the photoreceptor layer. This is another case here of the you can find that the ellipsoid zone is having defects here. So this is a case of cone dystrophy. This is another example of the changes in the ellipsoid zone, and this is identical in both eyes. and we have some blurriness of the ellipsoid zone with some changes here. And he's coming, this patient is actually a 40-year-old male, and he doesn't have any medical history or he's not on any medication, and he's healthy, and he's not having any history of looking in the sun or any laser or any photic injury. So these cases are typical that you have to take history more than once. This is a case of Popper's retinopathy, that this is a kind of recreational drug that is very commonly used in UK, and it is the composition is alkyl nitrite, and this makes some changes in the photoreceptor layer, and it is actually reversible when they stop this poppers. And about 10% of the UK general population aged 16 to 59 have tried these poppers, so you can find this in our clinics as well. The other thing is there any abnormality here that you can identify? Here this is the normal scan down here, and this is the abnormality. There is thinning of the ganglion cell layer here. So this can happen with the Glaucomatous optic neuropathy or other neuropathies. The other thing is the reflectivity that is abnormal. You can see here the reflectivity of the inner layers is very high in comparison to the normal scans that we have discussed. And this is here as well, there is some hyperreflective bands. We call this the PAMM, which is the paracentral acute middle maculopathy, which is actually ischemic condition that affects the capillaries. So on the fluorescein fundus angiogram there is no blockage, but on the OCT you can diagnose this condition, and here the near infrared reflectance, you can see some hypo reflective areas that indicates this. And after 6 months we find that the retinal layers that are hyperreflective, they are thinned. So you can identify here that there is inner layer thinning, which is indication of a vascular event that happened. So for the eye itself we cannot do any treatment at this stage, but you have to check the cardiovascular risks of the patient. So this is after 6 months here, and this is on the presentation. So you can see the thinning that happened. The reflectivity is important in identifying the pathology as well. So this is a case of retinal pigment epithelial detachment with underlying serous and some blood as well. So as you can see here, this is the hyperreflective appearance of the blood under the RPE. This is a case of the diabetic macular edema with the hyporeflective areas of leakage here, and this is the hyperreflective neovascular bands here, and the neovascular structures which indicating new vessels elsewhere that are attached to the vitreous here. And this is a proliferative diabetic retinopathy. This is another case of branch vein occlusion with diabetic retinopathy as well, and having this hyperreflective areas and hyperreflective foci, that some of them are indicating hard exudates and others are microglia with inflammatory condition. This is the drusen and the drusenoid PED here. This is a case of AMD, and this is a case of polypoidal choroidal vasculopathy with multiple peaks of the RPE detachment and some hyperreflective and hyperreflective areas under the RPE. And this is a case of cavitation and this loss of ellipsoid zone, and this is typical for the macular telangiectasia type 2 or MACTEL type 2. So in summary, most of the abnormal structures are hyperreflective, except if you have some fluid or cysts or cavities. And the normal structures that are hyperreflective are the nuclear layers, the myoid zone, and the outer segments of the cones. And the iso-reflective is the Henle fiber layer. So this table is summarizing the hyper and hyperreflective structures that we can see either normal or in the pathology. So the fourth step in our interpretation is to see the contour of the retina with the foveal dip here. So the foveal dip, you can find that there is extrusion of the outer plexiform and inner plexiform layers. You can find this foveal pit here, and the outer lengthening of the outer segments of the cones here, and the widening of the outer nuclear layer. So this four characteristics is very important to identify the normal and the abnormal fovea. So this is a case of is foveal hypoplasia. You see here the scan is central, and if the scan is central and there is no foveal pit, so something is wrong, which is a case of foveal hypoplasia. There is a nice article as well in 2011 in Ophthalmology describing the grades of the foveal hypoplasia. And to make it easier for us, so you have to check the fovea if there is extrusion of the plexiform layer, the outer and inner layer, if they are not present in the foveola or the center part here. So this is not foveal hypoplasia. And if not, so we are suspecting foveal hypoplasia. If you are suspecting foveal hypoplasia, you have to ask yourself another question. What about the inner segment and outer segment junction? Is there any disruption or not? If yes, so this is a case of atypical foveal hypoplasia. If not, this is a typical foveal hypoplasia. You have to see if there is outer segment lengthening. If yes, you see the foveal pit. If it is present, so this is a grade 1 foveal hypoplasia. If not, so this is a grade 2 hypoplasia. And if there is no lengthening of the photoreceptors and the outer nuclear layer is widened, so we'll see. If it is yes, this is grade 3. So you see here the thickness of the outer nuclear layer is thicker in the middle than on the periphery here. If not, this is a grade 4, and you see here the widening of the or the thickness of the optic of the outer nuclear layer is the same all over the scan. So this is a grade 4 foveal hypoplasia. So this grading is helping a little bit in predicting the visual function of the patient. This is another case here. I want you just to tell me what is this shadogram showing here. So you can find here that the lines are irregular here. So what is this? Okay, this is a Foveal Hypoplasia, but this thing here in the shadogram is an indication that the patient is having nystagmus. And the other thing is, what type of hypoplasia is this? So first, there is no extrusion of the plexiform layers, and there is no foveal pit, and there is no lengthening of the photoreceptors here, and there is no widening of the outer nuclear layer. So this is grade 4 hypoplasia, and this is a case of albinism. Then our fifth step in the interpretation of the retinal spectral domain OCT is the choroid, which is very important now. The identification of the choroid, first you have to check the layers. This is the choriocapillaris layer here, just under the RPE Brooks membrane complex, and then the satellar layer, which is the layer of the small blood vessels, then the halar layer, which is the area of the large blood vessel, and then the choroidal scleral junction, which is the end of the choroid here. And to see the choroid in more details, you have to order the EDI imaging, or the enhanced depth imaging, on the OCT machine. So this is a case of thickened choroid, and we want to know exactly how much the thickness of the choroid. You can see here, this is the enhanced depth imaging. So this helps in identifying the details of the choroid more than the normal scan. And the thickness of the choroid, there is a great debate about the what is the normal thickness of the choroid. It is variable, and you have to identify, is it diffuse first, is it diffuse or localized thickening. So if it is diffuse, so this makes us think about the pachychoroid spectrum, and the normal thickness is about 350 microns. It's variable in age, sex, other diseases, and the refraction of the eye as well, so it is variable. But this is the according to the recent evidence, about 350. Or you can roughly say that it is like the retinal thickening, but not in the center here, but just on the paracentral area. So if you find that it is equal to the retinal thickness, so this is not thickened, and it is temporally more thicker than nasally. In myopia, it is thinned, and you see here, this is the end of the choroid here, so it is actually very thin. If there is focal thickening, like inflammatory causes or neoplasms, you have to identify this thickening. And if there is rare condition like choroidal macrovessel, one of the vessels here is hugely dilated, so this might give you this localized thickening. Or if there is choroidal folds, or if it is thinned in a certain area, like the focal choroidal excavation that can happen with the central serous chorioretinopathy. If we find that the photoreceptor layer is lining this choroidal thinned part, or the choroidal excavation, so we say that this type is conforming. If we find that the photoreceptors are not lining this kind of thinned choroid, so this is non-conforming type. And the theories about this, that it might be an ischemic area that happened or choroidal insufficiency. The sixth step in our interpretation is to look in the vitreous. Now we have to look in the vitreous, and we can see that there is this line here. This is called vitreomacular adhesion, and this is the pre-retinal bursa here above the fovea. This is normal, and if there is vitreomacular traction like this localized area here, we have to identify this as well. And this is another case of vitreomacular traction with cystic changes due to chronicity. And if there is a macular hole, so there is no continuity of the retinal structure with some cystic spaces here. There is a nice article as well, the International Vitreomacular Traction Study Group classification of the vitreomacular adhesion, traction, and macular hole. So this gives us an idea about the vitreomacular changes. So we have vitreomacular adhesion, then vitreomacular traction, and then the full thickness macular hole, either small, medium, or large hole. And the vitreomacular adhesion, they classified it either focal or broad, and vitreomacular traction either focal or broad, according to the area that is adhered to the retina. And the full thickness macular hole, they classified as small, medium, and large. Then if it is having vitreomacular traction or not, and the cause is primary or secondary. So all of this will differentiate the vitreomacular relationship, and the can be different in the management as well. The vitreous, you can see some cells as well. So this is a case of vitreomacular adhesion with some cells. It is a case of vitritis. Here as well we can find that this hyperreflective structures with the, this is a posterior cortical vitreous line as well, and this is the epiretinal membrane with corrugation of the retina. But these structures that have shadowing are typical for the asteroid hyalosis. And if you can see here the near infrared reflectance image, you can find this asteroid hyalosis as well, and this can give you some details about the pathology. The seventh step and the last step is to identify the thickness of the retina, either it is thick or thin, and which structures are and which layers are thinned. So this is a case of epiretinal membrane with thickening, and this is a case of sickle cell parafoveal ischemia, and you can see here the thinning of the inner layers. The second thing is to check the thickness map as well, because this is very important in management of diabetic macular edema, as you can see in details in the diabetic macular edema management video. And either the thickening is more than 400 or less than 400, and this is the area here. It is the 9 areas of the ETDOR-S trial, and then you can identify is it clinically significant or non-clinically significant. But just make sure that which machine are you using, because some of the machines are measuring the thickness differently. So for example, Heidelberg Spectralis machine is giving little bit more thick retina, because it measures from the Brooks membrane till the inner limiting membrane, so it is about 50 microns more than the top cone machine, for example. So to summarize, I usually remember it with the mnemonic RCT. So to identify the OCT, you have to remember RCT. So first, is it right or left, and the quality of the scan. Second, the retinal layers, starting from the RPE, and check the layers and the reflectivity, and if there is any abnormal reflectivity with its location. The contour of the retina, the choroid, the vitreomacular traction, and the vitreous, and the thickness. Now this is a quiz. So this is a rare disease, but this is a finding in the OCT scan that I want you to answer this spot diagnosis question. So what is your diagnosis, or what's your differential diagnosis with this hyper reflective vertical band here that have shadowing? The first one that will write the correct answer in the comments of this video will have a nice prize. Thank you for watching this video, and if you like it, please subscribe and share and like, and thank you for watching.